This time I'm going to wait for the notification because I didn't get the notification. My phone buzzes. It lets me know to watch myself. Did you get a notification?
I don't know how to
There's my
set that up.
notification. That means that we are actually live. What's up, AdRock? How you doing?
I'm good, man. How are you? How are things? I guess school is going. How are the kids?
School is good. Drama, high school. We got high school stuff, so there's drama there. There's middle school drama, and then elementary school drama. First grade is, there's lots of stuff going on. This kid took my crayon. I wanted this snack. This kid had this snack. It's never a dull moment with 3 children. How about you?
Things are good, man. First and second grade, and yeah, it's been good. It's been
Yeah.
good.
It's funny, the whole summer I was trying to get work done at home and there's just chaos all over the house. I was like, I can't wait for school to start. And then once school started, it's so quiet in the house. I'm like, I am so lonely here in this house. I just don't know what's the right answer.
Lose, lose.
It's lose lose. Anyway, Adam, we're doing a shorty this week. Why don't you tell the people what that's about?
So I don't know. I think we just like to call it shorty. I don't know really what it signifies. I think maybe there's a shortened time between the last episode and this one. I
I like
think
it.
maybe it's a shorter episode or maybe it's not. But the real point of this is we've been eliciting questions, and we have hired a very famous. Well, you guys will see. Guest to come on and ask us questions. Some are his, some are other people's, and we're going to see how it goes and kind of put me and you on the spot for a change.
I like it. And if you've ever tuned into the show before, even one time, this is a name that will be very familiar to you. Ladies and gentlemen, boys and girls, please welcome Randy.
Jazz hands.
Welcome to the program.
Oh, thanks for having me. I'm super excited to be able to question the questioners, to
It's
ask for
really
knowledge from those who seek it.
it's really good because I know you're actually working part-time right now. You are over at Air Control at the local airport, and you're also doing this live stream with us, so we appreciate it.
Yeah, it's I can multitask. I can do both at the same time. The
Any Mayday calls that come in, please feel free to just go and do that because we value life and safety.
Sure, yeah, that'll happen.
All right, Randy, let's do it. Hit us up with the first question.
All right. So, in no particular order of awesomeness or importance, these are some questions that were fielded by some of the listening audience, and I just wanted to let's just start off. Let's start off with a softball. Let's start off one that's probably near and dear to Adam Green's heart. The blind subclavian. Is it a thing of the past?
Yeah, so I my answer is yes. It's a dinosaur of procedures. Now, with that said, there are those who have trained with the blind landmark subclavian, and power to them. They probably are very proficient. But I do not teach my fellows or residents how to teach the blind subclavian. In fact, I think Haney and I probably have different approaches in putting in. Sorry, I don't teach. I only teach them ultrasound guided, and I think Haney and I probably have different approaches to how we do it. Uh, but I feel pretty confident in how I teach it, and I think honestly, the scariest thing about it is that it's location, and if you can ignore that and just treat it like it's an IJ in a slightly different part of the body, it's easy to access with an ultrasound. I don't know, Haney, what do you think?
Yeah, it's a tough one, and I'm leaning to what you're saying, but I do think it's one of those procedures that, if you're training a fellow to deal with any situation at all, and even though IO drills are just everywhere nowadays, and you can make that argument that like, why would you even need to do any line that could risk injury, like pneumothorax or arterial puncture? I do like to give those fellows that access to that knowledge. So what I'll do is I'll typically walk through the procedures, not every time we do a subclavian, but every couple times, like a bonus procedure, if you will. And then I'll tell the fellow while we're all sterile, I want them to take the needle with the sheath on it. And based on the landmark method, I want them to put the needle where they think it would be and hold their hand at that certain angle. And then we'll go with the ultrasound probe and confirm it. And then after that, of course, we're still going to go ahead and use the ultrasound because, let's face it, we want our patients to get the same care that we would get or our family members would get. So that's the answer to that question. I'll just throw it in there for bonus, but I do think looking 5 or 10 years from now, it's just going to be one of those antiquated procedures.
Yep, totally agree.
All right. Well, continuing on so we're going to take a big jump in complexity here, and keeping on the procedure bandwagon train, let's go ahead with big question number 9. When do you decide to crike a patient?
Ooh. Well, I'll take this first if you don't mind, Adam. Yep, there it is, all muted. So I wonder, okay, so I was muted there. Let me just go back and check to make sure no one else is muted. Okay, so let me start that off again since I'm muted, and my apologies for that. My point here is that if you take your first look and you see airway anatomy that you could recognize, and you don't get that first look, then I'm okay for someone to go ahead and take another look again with doing something different. But if you take that first look and you don't see anything that's identifiable, or you identify this is going to be a very difficult airway, and the person's saturations are dropping, I alert the room of the possibility that a crike is imminent. I tell someone who's assisting me to go ahead and start prepping the neck. I get the tools ready. The hardest part about a crike is getting over the fear of doing a crike. And once the room is aware that a crike is happening, people start to get into the mode of like, this might actually happen. They've already gotten over that cognitive barrier and they're ready to go. So that's my answer to that question.
Yeah, I'll just say before it's too late. First off, audio good now? I hope everyone.
Yeah, audio is great. Yep.
Good. Yeah, my answer is before it's too late. I think it's a procedure that's simple. As intensivists, we should be prepared for it. I think if you're performing intubations and you're pushing paralytics, then you have a responsibility to know how to crike a patient. I think it's that simple. And it's also something to remember, you can have multiple people doing multiple airway maneuvers at once. And what I mean by that is someone can be taking a look as someone else is preparing for the crike, sterilizing the neck, getting your field ready, getting the tools you need. And, I think it's probably beyond this question. Even the approach to a crike should be as simplified as possible. I am not an advocate for the fancy crike kits that we sometimes see. I think a scalpel, a finger, a bougie, and an ET tube can usually get it done. And that's about it. But yeah, before it's too late is my answer.
And just to that point, I just want to say it again because it's such a perfect statement and something that I say that sometimes is controversial. If you're pushing paralytics, you better either know how to crike a patient or have someone who knows how to crike standing right next to you. Having that surgeon in-house, ENT in-house is not enough. They have other things going on. There's no guarantee that they're going to be to rush over to help your patient while they're desaturating. So either know it or that person should be right next to you on your shoulder.
All right, great. All right, so what's next? Well, since we're talking paralyzed patients, we're talking about the airway. Let's talk paralytics. And the first question into this would be from our audience, succinylcholine. Do you use it?
Oh man, I bet we can go back and forth on this. I don't use sucks ever. The only time I've ever used sucks is when I need a patient paralyzed without access, because you can give it IM and you can't give rock IM. Other than that, I have no utility for it. And I'd love to hear what you have to say, and I'm sure you have arguments for it. But yeah.
Oh, very few arguments for it. The only time that I use it is when I have a patient who I need a neuro exam back on. So if I have somebody who's seizing in status and I intubate them using rocuronium, then I'll go ahead and I'll use succinylcholine for that person. I need a neuroexam back. And some people say, well, now with Sugamedics, is there even a debate for succinylcholine? And again, unless it's the IV issue that you said, which again, if you're in a situation where you don't have an IV and you need to paralyze, there's other drugs you're going to want to give too. So put an IO in and go from there. That's my stance.
I'll say one. I agree that's a good example, and I will say that peer reviewed research is the gold standard, but I don't think there's anything more powerful than strong anecdotal cases that impacted you. And I had a case when I was a resident of a young man who was intubated by anesthesia, who weren't totally aware of his situation. He had pancreatitis and he had a hyperkalemic arrest. And I remember as like a second year resident that I thought to myself, I never want to be in that scenario. So I'm just afraid of it and I just don't use it.
Okay. So to avoid this becoming the airway and intubation episode, which we could talk forever, let's jump on to another topic. Let's just go for rando. When do you use, if ever, methylene blue?
I'll say for me, methylene blue it's one of those things where I think the vasoplegia is reversible, and a perfect example would be someone who is vasoplegic from cardiac surgery.
Yep.
So that would be a situation where I think that temporizing them with methylene blue would be helpful. But for everyone else, if I have somebody who's on multiple pressors and I give them methylene blue, it's a matter of time before that wears off. And if we're talking about something like sepsis, for example, the classic example where someone gets methylene blue because they're on multiple pressors. Okay, so I give them methylene blue, that sepsis is still there. They're still sick, they're still acidotic. And so I'll do it for someone who I'm just looking to prolong their time. Maybe I want to get family to the bedside so I can spend some extra moments with that patient. But I am interested to hear what Adam has to say about that.
Yeah, totally agree, man. It's that is the board answer, right? It is post cardiotomy prolonged vasoplegia. That's where methylene blue has been shown to have some efficacy. However, I do think I can remember patients with unexplained distributive pathophysiology, low SVR, and I don't know why, warm extremities, but don't seem septic, and I'm not really sure what's going on. And it's kind of like, don't let the sun set without giving methylene blue, right? I think that's the saying. Sometimes I've given it and it's never helped, but one of these days maybe it will, and I'll look like an absolute genius. But it's usually like the fellow says, "Hey, how about methylene blue?" And I was like, "All right, go for it. As long as they don't have G6PD deficiency, what do we got to lose, right?"
Look at this guy dropping the med school physiology. Love it.
Yeah, that's a little internal medicine for you, ER, buddy.
Good one.
All right.
Meanwhile, I'm the one with the glasses.
Yeah, that's right.
You.
So since we're talking about vasoplegia and shock, let's move on to when do you add vasopressin to your regimen for patients with septic shock?
This is, I think, like the number one question I get asked by like residents or nurses or fellows. What do you think,
easy.
Adam? Well, I'm curious to hear what
you add the steroids. When you add the steroids, I add the vasopressin.
Done. And I completely agree too. But the question is, when do you add the steroids then?
15 of norepi.
Yeah.
That's my cutoff.
Yeah,
you had to pick a number, and I think you got to be absolute. And there's evidence to different pathways. I think you need to just create an algorithm in your mind and then continue to use it in the same way. Just like, I'm an advocate once vasopressin. I think the more interesting question is, when do you stop it as opposed to when do you start it? And so I'm an advocate of, once it goes on, the norepi has to come off before the vasopressin stopped. And that's just easy communication with nursing, because I think it's non-titratable and it gets confusing sometimes. If you stop it when they're on 3 of norepi and then all of a sudden they're on 10 of norepi, are you supposed to restart the vaso or just keep going up on the norepi? And it gets a little confusing. So I drop the norepi, drop the vaso. If they're in shock, restart the norepi. If it hits 15, restart the vaso.
Do you ever titrate off the vaso? I know you're not supposed to titrate the vaso, but are there ever situations where that person just likes vaso a little bit better and they just you can't get off of it? You ever titrate it off?
I don't. Do you? I don't know.
Yeah,
I,
I'll
I
do.
think at one point, yeah, it makes
Yeah,
sense,
I
but
mean,
I haven't.
I'll do it just because there's no real rules in medicine. I know there are studies that support the non-titration of vaso, but I have had some people, and they tend to be elderly patients, maybe patients with chronic illnesses that are a bit vasopressin deplete, and they seem to like vaso. Or if you have the person who's like really sensitive to norepinephrine, like they get a lot of arrhythmias, PVCs, maybe even AFib with RVR, and so I lean towards the vaso, and I like vaso way better than phenylephrine. So I might have that person that's like, but they're on 0.03. I'll just titrate them off, and I don't know if there's better evidence or if what I'm doing is wrong, but so far it's seemed to work.
Yeah, I don't know why it would be wrong, but yeah, makes sense.
All right, so we both have strong opinions on when to start something. Let's talk about stopping things. Talk to me about the role of continuous albuterol nebs in adults. Fact or fiction? Useful medication, useful treatment, persistent tachycardia. Is it just a few more minutes going to do it?
I'll let you do that one, Adam.
Oh man, I can't do it. Where do I go? I think we over albuterol people. I think the doses we give are crazy. I think that there is a role for the literature I've seen that is supportive is in specifically in the pediatric population that has clear acute reversible bronchospasm. I think that COPDer, who's 60 pack smoker, comes in a COPD exacerbation and we just slap them on continuous albuterol. I just don't do it. Even in adult asthmatics, I just don't see the evidence. And you're making fun of it, Randy, but I do think the anxiety, the restlessness, the hypertension, the tachycardia, it's real. And the doses of albuterol that we give are even just the PRN doses, the full 2.5 milligrams, 5 mLs is a lot. It's a lot. It's more than what some just handheld nebulizer or handheld MDIs are.
Yeah, I'm 100% with you. Um, what I do if I'm going to continue the continuous is, oh, let me start over again. When people use continuous, I find that they're just hoping that the next 10 minutes is going to work, the next 20 minutes is going to work, rather than progressing down the asthma algorithm and saying, okay, well, what's the next drug that we can use? What's the next receptor we can hit? Should we be using epi next? Should we be using ketamine? Should we be doing something else, something different? And so when I see people using continuous, I'm like, okay, what else are we doing? It's like, oh, we're just going to wait for continuous. It's like, it's not working. And just like most things in medicine, if something's not working and the person is very, very sick, the next thing to do is progress to the next step. And I agree with you. A lot of the side effects that happen with these continuous nebulizations cause more harm than good for our patients, and also distract from the ultimate care.
I do want to make one point though, is that I understand our controlled world upstairs is different than the chaos of the ER. So I do understand that, sometimes it's RT is busy. Sometimes you do need a couple nebs, and sometimes it's easier to just order the continuous nebs because it's going to get done. So in no way am I faulting emergency room physicians for making that decision. I just don't do it. And usually when I take over a patient in that scenario, I stop it.
By the way, is now a good time to mention that people should like this video and subscribe to the channel? Is now a good time?
This is Dr. Sharp, the Control Tower, requesting all present to like and subscribe. Hit that button, give us a thumbs up.
Okay. Well, there you go.
Smash
There you
this
go.
button.
Straight from the control tower.
All right.
It's out there.
So now that I've regained control and I'm controlling transmission, we talked about a medication that seems good on the outset, is good, but has some untoward side effects when used inappropriately. Let's talk about dopamine. Should we just take it out back and shoot it?
Yes.
Not into ourselves, metaphorically, old Yeller style, if you will.
I wouldn't even shoot it into the ground, because what did the ground ever do to you except support you and keep you afloat? So, it is a very, very rare occasion where I say dopamine. In fact, as we're saying this question, last night was the first time in a few years that we had a patient who could have stood to use some dopamine. It's only for patients who are hypotensive and really bradycardic. That's the only time I would think about it. And of course, if a cardiac surgeon wants to hang it up. But the data on it is just pretty terrible. low dose dopamine, renal protective dopamine. We have to, at some point, we just have to stop doing it because the data is all there. So yeah, in my opinion, if I owned a hospital, there would be no dopamine in that hospital.
Yeah, I mean they're out
Okay.
of our code. They're out of the code cards, and I just don't think there's much use for it. Even if you listen to the intern present the patient on max pressors, you'll notice it does not include dopamine, generally speaking. So I think it's even out of our vocabulary.
All right. Well, so we've talked meds, we've talked about blood pressure control, we've talked about procedures. Let's talk about everybody's favorite recurrent admission diagnosis. You know them, you love them. They are the DKA patients. And somebody out there in the ether has submitted a question that I would not have thought to ask. Do you feed them? Like ever? I don't know. It seems an open-ended question.
Is there an
Like,
interval of time?
do they deserve a cracker on the way out? I don't know. But talk to me about your feeding strategy in patients that are admitted with severe DKA.
You want me to take it? You want to
Sure,
go, Haney?
you got it.
Yeah,
Adam.
I feed them. If they're hungry and they want to eat, and they don't have some intra-abdominal pathology that I'm concerned about, I feed them all. You know, and you can't give me a pH that would change my mind. I think if their tachypnea allows it, and they want to eat, and they're not crazy nauseous, then I give them food. And part of my explanation is, number one, it's always better to use the gut. Number two, we always have on insulin, and then we start dextrose IV when the sugar is below 200. So how is this different? How is it different letting them eat? And I think I, I wish I could cite a study, but I'm relatively sure that the length of the hospital, the length with continuous insulin, probably wouldn't differ that much between those that are fed and those that aren't. But I feed them.
Yeah, I mean they're on an insulin drip, right? So
Right.
I mean their sugar is about as controlled as it could be. So let the person eat, let them be comfortable. They're miserable as it is with everything they're dealing with. Now I think we're talking the same thing. If the person's like pH is severe, they're tachypnic, those are not the people we're talking about in this situation. We're talking about the person who comes in with DKA, who needs a drip, who really needs the ICU for the nursing care, and those patients, they should eat, in my opinion.
Although I'll make a bold statement. I don't think those that shouldn't eat want to eat. Right. I've never been in the
Yeah,
scenario where I'm arguing with them. Right.
yeah, fair.
I'm like, you can eat. They're like, I can't eat right now. I was like, okay, then
Yeah,
let's keep moving. So
yeah, right on.
yeah,
Let's talk
feed them
about some
all.
other people that let's talk about some other people that maybe you should or should not feed. Um, let's talk about people that are really sleepy. Let's talk about those people who uh, overdose on opioids. You're in the unit, you're running the show, you got a full census, you got stuff going on, you get an opioid overdose in the ED, and what's your approach? Are you going to keep Narcan pushing them, 0.2, 0.2, 0.4? You can put him on a drip, or are you just going to tube him and let it ride it out? And when he wakes up and extubates himself and leaves AMA, see you later.
So
First off, I want to take a halftime break and say, Randy, slow it down. All right, you're doing too good of a job. You're gunning for the host, and that's making me a little uncomfortable. So that's him
I
gunning.
think I
All
lost
right, go
audio
ahead.
there. Can you guys hear each other?
Yeah.
'Cause I
Oh, I
can't
hear
hear
Adam
you
even in
guys.
my sleep. After 2 years,
And something's up over here.
Oh, give us a second. All right, audience, can you guys hear me?
technical
Do you want me to
difficulties.
talk? Let me talk about Narcan until Haney's back. Unless you're back now, Haney.
So you guys can hear each other because I
Uh
can't hear
huh.
you. Randy, you can hear Adam,
I hear
and can you
this
hear me?
guy. I do. I
You
hear
guys can hear
you,
me?
We
Hmm.
can hear
That
you,
must
and
mean
we
it's
can hear each
an
other.
issue on my side. So go
but you're a
ahead,
little
Adam. You
crackly.
start
All
answering
right,
that
so let's
question,
talk
and
about
then
Narcan.
let me get different set of headphones on.
So I number one, it's impossible to answer the question for every patient, right? So let's just say most people who have excessive opioids probably, and maybe this is a generalization, are more likely to be young and have normal cardiopulmonary status, right? And the reason I say that is because it means I'm less concerned about the effects of intubation as opposed to someone with chronic lung disease, in which case my algorithm may change a little bit. I view Narcan usually as a litmus test that I have the correct diagnosis. So if they're encephalopathic, I think it's opioid. I'll give them the Narcan drip. It gives me an answer. And I tend to like to support these without continuous pushing, and I almost never use a Narcan drip. The reason for that is, once again, it's a little bit kind of personal experience, but I definitely have seen bad pulmonary edema. I've seen some pretty severe arrhythmias, bradycardic and tachycardic. I think tachycardic is the classic. I've seen severe bradycardic arrhythmias. So I would rather, if they're young and healthy, intubate, let them sleep it off, and then push to extubate. And that's just been my personal experience. I don't mess around with too much Narcan.
So I've lost sound. So you guys just keep talking amongst yourself, keep answering questions. I'll keep troubleshooting over here because everyone else can hear us.
All right, cool.
Adam,
let's keep
it'll
going.
be just like old times, a discussion between.
Yeah.
All right, let's bring it back. Let's bring it back to first week of fellowship. Let's talk about femoral venous access. Should we be
that's
doing
great.
them?
Look, and I love that we've lost Haney. We can get your input some too. I think what I'm supposed to say is never use the femoral vein. That always find a neck vein. I think that there is certainly evidence that say they're higher CLABSI. I think, however, the best way to decrease CLABSI is appropriate insertion, appropriate maintenance, minimize manipulation of the line. And that's probably significantly more important than the site. So do I look to put femorals in? No. Have I put them in? Yes. Do I want them out quickly? Yes. But I think it's still within arsenal that we use. Yeah. How about you? What do you think?
I agree. The patient and the patient's condition tell me what should and should not be done. The patient's anatomy, patient's amount of sickness, what else is in their neck, what's in there, what is already going on, whether that site is infected. So I'm a never say never person, but usually I use the time with the femicin to look for other long-term stable access, and I get it out within 24 to 48 hours.
Yep, totally agree.
Oh. All right, so we'll move on. Haney will let us know when he is back. Never at a loss. So you've intubated, and now you've femoral lined your sick patient. And this is a sick ARDS patient. You have your access, you have oxygenation, but you need to titrate the PEEP in this sick person. How are you going to do that? Are you going to look at just the ARDSnet table and go high or low? You're going to look at the driving pressure? How are you going to do that?
Yeah, I think if anything we've learned from COVID that it's a heterogeneous group of diseases. I do not use the ARDSnet table. I don't think I've looked at it in years. I think it's a phenomenal source for PEEP titration for the learner, but I don't necessarily think in the seasoned physician that it's within their arsenal. I primarily use driving pressure. I hope everyone here knows what that is, but I generally look at variety of PEEPs. When you switch PEEP, you need to give it 30 seconds, 60 seconds, maybe even a couple minutes, repeat and check what your plateaus to understand what your driving pressure is. And then I also use stress index. I think looking at that pressure time curve and understanding if it's pulled down or pulled up, I think that gives you a lot. And all of this, of course, is understanding kind of what a normal plateau is. And I know we're taught 30, but I think that there's a variety of things that affect that. That a 30 may not be normal for everyone. And so it's understanding that.
Sure, that's fair. Let's move on. While we're talking about PEEP, we're talking
You
about
can answer too.
titrating it.
We can just be you and me to want to do it. If you agree and want to move on, you can. But it doesn't just have to be me.
I definitely agree. I agree that that the high and low PEEP tables and the ARDSnet protocols are great ways to capture the most amount of good for the most amount of patients for the most amount of physicians. And then as you progress through your knowledge and experience, you know when to go sort of off script and apply it to the individualized medicine to the individualized patient. And It's not just the patient, it's their lungs, it's their disease process, it's what they looked for, they got sick, and what normal is in them. So I agree completely. So let's talk about patients and PEEP, and let's talk about not lung compliance, static compliance. Let's talk about chest wall compliance, and those maybe that larger patient with a lot of chest wall weight. what PEEP do you start on those pills, and how do you titrate that?
Yeah, I wish I knew. It's based on oxygenation. It's based on plateau. I'm significantly less concerned about what a normal PEEP is for it, and much more aware of what the airway pressures are as a result of that PEEP. Um, so I don't have an answer. I wish I could tell you BMI of X means this, but there's so many others, right? How about someone with um, post radiation from lung cancer and has some restrictive lung disease that can't expand? That probably affects airway pressures. How about someone? There's probably a dozen scenarios can come up that would affect the airway pressures, but I don't know the answer. I'm
Yeah,
not
I think.
afraid of extubating on a PEEP of 8 or 10, if that's part of the question too. So I don't know.
Yeah, well, these are user generated questions, the burning questions from the people that watch us every week, and we thank them for it. But, just like you have to know when to go off script. So if it's useful to add knowledge to our questions, then we'll add knowledge. And I always say when people ask me how much of something, or, how much do I have to get this, or how much does it take for that? I say, well, how much water does it take to fill a cup? And the answer is, how big is the cup?
Right.
You titrate it to the effect that you want, and you move on. So I think that's a fair. Uh, so man, a lot of intubation questions. We have an audience that just burns with knowledge for intubation, um, and I'm gonna stir their thirst here. What is DSI, and do you use DSI? Any algorithm for DSI?
Sure. Do you know what DSI is? So
I'm going to go with delayed
sequence
sequence intubation.
intubation. Yeah. So I think so. First off, I think there's a couple components worth talking about. First off, rapid intubation. So I trained where I probably use paralytics, I would say less than 25% of the time. I now probably use it 80 to 90% of the time as I become even more comfortable with airways. And there's a variety of reasons to that. The concept of delayed sequence intubation is really fascinating. And I would say there's probably, and the idea is that you give some sort of conscious sedation. I think ketamine is going to be 1 to 2 mg per kg is usually the drug of choice. However, I've definitely used touch of Versed, maybe a little fentanyl to help do some conscious sedation. And who do we do that on? Probably two populations. The first is those that are waiting to be pre-oxygenated in a safe way. So you have someone who's hypoxic, needs BiPAP before you really put them out for intubation, and you choose to give them a little anxiolytic, put the BiPAP on, wait some time. It needs to be secured, but it's not impending doom, right? The second is someone who you're worried about post intubation, hypotension, or shock, and you're just not confident you have adequate access, and they're not allowing you to get adequate access. So those are the two patients that you give ketamine, put BiPAP on, do the procedures, then proceed with intubation. However, this concept of RSIing should be really thought about because, right, if you do it for everyone, it means it must be wrong for some of them. And so I encourage people to try maybe just etomidate or maybe try an intubation with propofol in the right scenario. It's not always etomidate, rock, intubate.
Yeah, since we're having a conversation while we wait for Haney, I'll agree. The if you watch anesthesia do enough of these in the ER in a stable patient, you see the, hey buddy, how you doing? A little bit of propofol, hey, a little bit of phenylephrine, get them to that nice, perfect, happy spot. You achieve a little bit of apnea, and they're closing their eyes. And then, okay, we're all whispering, give the paralytic, and 45 minutes later, the patient's intubated. I've always been in the sick, crashing person, get it done. The faster you get it done, the faster you achieve paralysis. As long as I have that bag of Levophed hanging, as long as I have access, as long as I know that the rapid push of either.
Oh, hello. I can hear
Oh,
you now. We're back. All
okay.
right. Uh, yeah.
So let's
So
keep moving.
let's
We'll
keep
keep
moving. Yeah.
moving on. So we talked about delayed sequence intubation. What could be more delayed in intubating a patient than keeping them awake while you do it?
Sure.
Uh, you walk me through how you would perform an awake intubation. Well, let's just start. How many times have you done it? And then as you go through your mental reps, how would you do it And as an aside, the person submitting this question says, "Awake fiber optic intubation?" Question mark.
Yeah. All right. So I think these are very linking questions. So number one, if we go a little bit back to RSI, so I agree with you. Fast and furious is usually my approach. However, I do think thoughtful understanding about hemodynamics and appropriate preparation is incredibly important. I think that you can avoid that post-intubation hypotension if you're very strategic about it. Um, Now, in terms of fiber optic intubation, so I think there's two populations which I'm concerned about, and that's either those that are incredibly hypoxemic or those that are incredibly acidotic, and I want to kind of maintain their natural respiration. And so there's two approaches I take. The first approach is RSI, where I push the paralytic first, followed by uh, my sedative, which is generally going to be etomidate. And someone says, "That's crazy. Why would you paralyze someone first?" And it's all about time of action, right? It's all about time of action. So if you flush that rock with etomidate, the etomidate will be doing the magic before they're paralyzed. The second approach is this fiber optic versus awake intubation. And I think they're almost synonyms. So I think of there's two ways to do this. Usually I use ketamine. How many times have I done it? I don't know. That's a secret only the closest people get to know. I would say, can I say more than 10, less than 50? We'll
A
put it at that.
handful, whatever
Um,
a handful is.
and yeah, that's right, a handful. So how do I do it? The first thing is oxygenate appropriately, right? So high flow, if you're going to be going through the mouth, a non-rebreather that can still expose the air if you're going to be going through the nose. So definitely oxygenate. Sit them up, get the diaphragm down. Let them, if you're going to be keeping them awake, let them breathe. All right. If you're going to go through the nose, plenty of viscous lidocaine. Make sure that you give them the correct anxiolytic. Uh, Obviously, have all your airway material available. If you're going to go through the mouth, a huge fan of the Williams airway. I think probably the hardest part for people who don't bronch routinely is understanding how to get past that tongue and all of the soft tissue. And so Williams airway just helps guide it down. Obviously, please load your ET tube before the bronch goes in. You don't want to be in that scenario. And usually just a piece or a piece of tape at the top of the ET tube. Highly recommend to tape it to the top of the bronchoscope. And then get your view. Make sure you see the rings. Have your RSI meds actually ready so that once you pass the tube through the cords, they don't cough it back out. I always have 1% and 2% lidocaine, so I shoot 2% above the cords to really try to numb it as I'm going in. And sometimes, I think the hardest thing is understanding when to go. So you see the cords, hang out, wait. As soon as they take that deep breath and they open, then push through. You don't, you can that 2 extra seconds of pause is really valuable, and don't just push through and damage the cords. Haney, are you back, or are you just viewing? No, not
All
back.
right, we're just viewing.
All right,
Well,
let's just keep going.
so we've put tubes in groins, we've put tubes in airways, we put tubes in the subclavian. Uh, let's talk about another type of tube that we don't talk about that much, which is from their bladder pressure. We use a manometer well, we don't use a manometer. We hook up our CVP line to the Foley. So when we're talking about bladder pressure, we all know about intra-abdominal hypertension, intra-abdominal compartment syndrome, but do you have to be paralyzed to diagnose this? If someone's not paralyzed, you just go bladder pressure is useless and disregard it.
Love that question. I think first you have to let's appreciate that. How do we diagnose an acute abdomen? Right? It's physical exam, disease pathology, right? For sure, not just some number. And secondly, it's important to know what is a normal bladder pressure. This concept of abdominal perfusion pressure is key, right? Just like your CPP, you have an APP. So what is your MAP? What is your intra-abdominal pressure? What's the difference? And so you could take someone who has had prior surgeries, that is really obese, that has an incredible amount of ascites. They may have an elevated intra-abdominal pressure that has no significance to their perfusion pressure. Just like you can take someone who has a relatively normal intra-abdominal pressure, um, but is hypotensive, in which all of a sudden their IAP is very low and can be disastrous. Their abdominal pressure. Does that make sense? And so I think ideally they're paralyzed, but sometimes patients are awake and I want to do it. As long as they are comfortable, they're not bearing down, they're not grimacing. If they're on the vent, that they're sedated enough and they're kind of synchronous with the vent, I think there's value in that intra-abdominal pressure. I also think there's value in trending it, much more value in understanding serial measurements as opposed to just one standard measurement. So I do not, if I have the luxury of paralyzing, I will. I'll use 50 of rock, but I don't have to.
Oh, great answer. Great answer. I, as easy as it would be, I always get confused in my head. Accurate but not precise, precise but not accurate. Which is to say, maybe the number isn't exactly the exact calibrated, correct time, but the change in it is a true reflection of a change in the patient's condition. And I think that there is some validity in marking the delta in somebody. Sometimes it's good to know worsening, improving. So I think that that's a fair statement. Let's reach out to our ID friends, the masters of the history and physical. And let's talk about antibiotics, but more importantly, let's talk about the treatment of MRSA and what the swab, a positive MRSA swab, means in your treatment of a septic patient or someone who has a proven infection. You know, I guess all of our patients would be septic, fluidly septic when they get to us. But let's talk about the MRSA swab and how it changes your life and your behavior.
I'm just happy you didn't use the word procalcitonin, because I think our man Haney over there,
3.5.
he is a hatred of procalcitonin. The MRSA swab, let's first say that it was done right and that we're confident in the results, right? Just like, the negative COVIDs because you forgot to put it in the nose. And so how do I use it? First off, there is very high specificity. There's very high negative predictive value. So what does that mean? Specifically with MRSA pneumonia. And what does the swab indicate? That they're colonized, that their nair is colonized by MRSA, right? So if it's negative and I'm treating them for hospital-acquired, healthcare-acquired, ventilator-associated pneumonia, I feel relatively confident in stopping the vancomycin. The one rare scenario is where I have a culture that is showing me MRSA, right? If I have a sputum culture that says MRSA, I'm probably going to continue it, but and say that's the one-off, right? But specifically with pneumonia, I feel comfortable. Now, soft tissue, CAUTI-related MRSA, I don't know. I usually like to have a culture to know what I'm doing. If it's a drug, type 1 diabetic drug user who comes in and it has a MRSA negative swab, and I'm worried about some sort of bacteremia that hasn't resulted, or cellulitis, I'm probably going to keep the vanc on until I'm really positive.
Sure. I think a couple times in that statement, you might have used MRSA and Staph aureus, or MRSA and GPCs and clusters sort of interchangeably, just when you were riffing there. But I think everyone got the point. And I think that that's a fair assessment, right? You know, it's one of those tests, much like a ProCal, that only means something to you if you want it to mean something to you. And you're going to do what you were going to do anyway, and this just gives you more data to support that. So we talked about antibiotics. We're winding down our listener-supported questions, and if you haven't yet, those of you who are remaining, show me how much you appreciate all of the listeners out there in our lounge nation, and hit the like button and the subscribe button. It really helps the algorithm, and it helps more people to get the kind of information that you're getting. You may be here because you know these incredibly intelligent, personable gentlemen, and they turned you onto this podcast, or maybe you're in Finland or someone in the UAE like we've seen before, and maybe you just stumbled upon it. But help your friends in the critical care world. Help it show up on their YouTube algorithm. Hit the like and subscribe button, okay? And participate in the chat on our next show, okay? So we're winding it down. We've talked about a wide range of subjects. I think a good place to go now is let's talk to, I don't know, is there a lung doctor in the house? Is there a lung doctor in the house? Let's talk about asthma. And moreover, this person is submitting a question that says, when do you use intramuscular or intravenous epinephrine in somebody that presents with an asthma exacerbation?
Yeah, that's an awesome question, and I've been pushing. I think we're going to do an entire show just on status asthmaticus. I think ventilator manipulation. I think adjunct treatments. It's such an interesting area, and I will say rarely. I have used both. I think IM or subQ. I prefer to use that. The times I've used intravenous has led to pretty severe tachyarrhythmias and hypertension. That it can be pretty damaging. But I have used it intramuscular. I will say I prefer. I really like to exhaust everything else, right? Your ketamine, your magnesium. I have had huge success with inhaled anesthetics. A little logistically challenging because you have to take a sick patient and they really have to go to the OR for the anesthesia machine. But I've had good use. Don't forget ECMO. But yeah, I use it sometimes. I wish Haney was here because I'd love to hear what he has to say about when he's used epi for severe asthmaticus. I think it can be challenging, but we can't hear him.
He's
Can
in
you hear me
the
now?
emergency.
Yes,
Oh, we
can
can.
hear you.
You're back.
It's a miracle. It's a miracle. Well, let me tell you, first of all, I think you both could do a show on your own. I was having more fun listening to both of you vamp than me being in here. So I just want to start off saying that. Secondly, I will say that, epinephrine is not something I'm grabbing for, but, consider, if you will, the patient who comes in who's really tight, not moving a lot of air. And in those situations, you can give and we already talked about this continuous nebulization, but there's no beta agonism that's really happening. It's not getting to its end organ, the alveoli, right? Or I should say the terminal bronchioles for bronchodilation. In those cases, whether you use epinephrine or terbutaline, but you're going to have to use another beta agonist somehow. And those are the situations where I use epi relatively early. I'm not going to use it for someone who comes in with mild asthma or moderate asthma, but the person who's not moving a lot of air, where I think that albuterol is just tickling the dead space, that's when I'm going to be giving the epinephrine because I want to bronchodilate them. If you don't feel comfortable doing that, then you probably should, if you're not comfortable giving epi, maybe not be in this line of business. But if you want to make an argument against it, then try something like ketamine early on, subdissociated doses of ketamine, which will also bronchodilate by a different mechanism. But still, the best beta agonist that you have when you are completely clamped down, I gotta say, is epinephrine.
Thanks for that. And I have to say, when you guys do your full hour on status asthmaticus, I will be there with popcorn. I will be projecting it on the big screen because, as someone who has been in a multitude of institutions of a multitude of sizes and resources, and OR staff, and vents that can do this and vents that can't do this and things like that, it still gets my pulse up. It's still just this nightmare scenario that you do your best, but you just don't know how it's going to end. And I've seen it go a lot of different ways. And so I could think of a million things to ask about status asthmaticus, and I can't wait for that episode. And I'm sure the audience will enjoy it too. So I'm really going to advocate for that. You should get a pulmonologist. So let's finish it up with, I feel like we owe it to the listeners who took the time to submit their questions to finish out with these last three. So let's do a little rapid fire. Quick hit, general approach to analgesia in the intubated patient.
IV push.
Okay.
So PRN IV push fentanyl is my preference. The times I use drips are acute surgical pain and chronic opioid dependence. Other than that, I'm using IV push. The comment I make is that 25 micrograms an hour of fentanyl is the equivalent of oxycodone 5 milligrams every 4 hours. So you take that 90-year-old with Parkinson's and intubated for pneumonia, and you put them on 25, which becomes 100 micrograms of fentanyl, and all of a sudden you're giving them 20 milligrams of oxy-IR every 4 hours by doing that. And then you wonder why they don't wake up. So IV push, IV push, IV push.
Yeah, I'm in agreement. There is a little bit of practicality when it comes to nursing, especially having a nurse if you're going to be going the Q1 hour route. But to Adam's point, we got to be using the gut. Find out where the steady state is, find out where their pain is, and then just use the oral route. Q4 medications orally is something definitely nursing can handle. During the pandemic, which I hope we never see any situation like that again, to have a nurse having to go into a room giving, PRN medications would be, unbelievable to think about. But since we're not there and we're back to 1-to-1 and 1-to-2 care, I think that is definitely something that's manageable. And to Adam's point, we got to keep people on alert, as awake as possible, minimize delirium. Those are the more important things that we're realizing as we get further along in critical care sciences. We can fix disease, but can we let the people leave the ICU cognitively intact and right back to their lives as usual?
Yeah, and I think a lot of times, honestly, the fentanyl that's being used is being used to not treat pain. It's being used to treat agitation. So even if you just think about the maneuver of, let's say they're on 25 of fentanyl an hour, they're agitated, so the decision is made at the bedside to go to 50 an hour. That really doesn't increase the infuse rate that significantly enough to actually see any difference. So, so then it goes to 50, and then they wait 20 minutes, and it goes to 75, and it's 100. If you had taken that patient and just given them a bolus of 25 or 50 micrograms of fentanyl, you probably would break that agitation cycle and not have to continue to go up. So I think it's really, I know it's challenging, but I think it's important that we try to push for dexmedetomidate and IV pushes of fentanyl. And this isn't like the freshly intubated patient that's still unstable. They're definitely patients that need to be deeply sedated, and I'm all for it. I'm not advocating against it for those. But this is the majority of patients, I think, once you get through that acute phase, we should transition quickly.
Yeah, personalized medicine and the right thing isn't always the easiest thing. So I have to agree with both of those. Finishing up our last two listener-supported questions. So we've talked a good bit about intubation. We've talked a good bit about paralytics. Let's talk about paralytic during intubation. So do you always use a paralytic? And I think this question, it's worded a little bit differently, but I think they want to talk about paralyzing the intubated patient. I think this is what they're getting at. And they want to know, how are you titrating it? Do you trust the BIS monitor? And I don't want to put you on the spot, but what does BIS mean? And if they're prone, do they have to be paralyzed? And I know that during the pandemic, Adam and I talked quite extensively because, I leaned on him during fellowship, and I still lean on him today, even though I don't always admit it. And he had some strong feelings on this that really helped carry me through a lot of tough situations. So just to recap, after my small moment of hero worship, how do you titrate it? If you're prone, do you have to be paralyzed? And do you trust the BIS monitor?
Well, I'll start off by saying that, there's a lot to unpack there. My goal when I have a patient who's mechanically ventilated is to keep them as light as possible. Let's just start there. We know that keeping people deeply sedated, which goes along with paralysis, right? We don't want to have anyone who's paralyzed and completely awake. So if you're paralyzing, you're going to deeply sedate them. If you're deeply sedating them, you're greatly increasing your risk of delirium and post-ICU syndrome. So normally, no. I find few situations where it's necessary to paralyze patients. The ones where I find it necessary are people who you need better compliance of the lungs, and we're talking about people with ARDS. The severe asthmatic, staying on that theme, where it's very, very difficult to ventilate that patient. And then the question of can you keep your patients prone, not paralyzed? And I think that you can. There are certain situations where you can have a patient who's spontaneously breathing while they're paralyzed. Not every Adam is a big proponent of this, and I'll let him defend it. But I think we don't prone our patients early enough. We should be proning our patients, when they kind of reach the early moderate of ARDS, get them proned and get them better oxygenating, in which case I don't think it's necessary to paralyze those patients right up front. And then to your last question about BIS monitoring, you can find papers that say it's accurate, and you can find maybe a little more papers that say it's inaccurate. But at the end of the day, what else do you have to monitor your patient's level of consciousness? And although I don't really believe that it's all that amazing, it is something that we can look at objectively and say, this person's paralyzed. I'd like to have them not be aware of this. And so it is something that I do look to.
Yeah, I think we're running out of time. I don't have a ton to add. I mean, I think Haney hit all the right spots. Number one, I paralyze when I have to, not when I want to, and I only do it, and I do it for as short as period as possible. Paralytics is not a titratable drug; it's a yes or a no. I always titrate to train 404 to achieve what I'm trying to achieve, which is usually vent synchrony. Biz is tough. I think there's hospitals, well-known hospitals that use it. There's hospitals that don't use it, and they go by RAS. I think that it really depends, and sometimes it's nursing preference. So I don't want to comment too much on utility of biz, but no, I don't always trust it. Most of my prone patients are paralyzed, but not all of them. I could go on and on about proning, but we'll save that for another time. I think that answers it. Obviously, feed patients that are paralyzed. I don't titrate it, just stop it. When it's done, just stop it and see what happens. There's no like PF cutoff in ARDS. It means they have to be paralyzed. That's never been shown to improve mortality, and I don't think it ever will. Yeah, I don't know, Randy. Does that kind of answer your questions? Any other nuances to it?
No, I dealt with institutions that did both, that used the bispectral monitoring and that did not. Some people, some are what I would call RAS of -5 institutions, where you just drown them and you can't titrate in any direction but up as long as they are paralyzed. And they were somewhat, hesitant to do paralytic off trials or paralytic holidays. And I was at institutions that used the BIS monitor and trusted it reasonably well. And it's really institution dependent and personal preference and comfort with the nursing staff. So the only other question that was submitted from the audience by the way, I want to talk about the popularity of Haney Malmet. When it was just Adam and I talking, our viewership count dropped all the way down to 3. And then we got what I would call the Haney bump. When he came back on, it seems it went all the way up to 10. And now we've leveled out.
Yeah, it's my extended family. They only watch me, so they're not
He
doctors.
he's also 3.5 times cooler than you and I. It's just important to know that and accept it.
The math does work out. And I think that's a good point to end on. I think that, I just want to say that, as a viewer, I enjoy your show. I enjoy the genuineness of it. And I enjoy the variety of the guests and the effort that is put into it, and how good the guests and how much improved the production value has been. And I really appreciate you guys letting me represent your viewing audience and ask these questions. And, I will always be a fan.
Cool.
Not just of the show, but you guys as people. Because you make us better. Not everyone is at Cooper. Not everyone is at Penn or Pitt or Baylor Scott and White and have access to people like you guys. Some people are out there alone doing it on their own. Some people are in a small medical unit and just slogging it out, and it's them and an ER doc and a surgeon and an anesthesiologist holding down a fort in small town USA, and you guys matter a lot to them.
Thanks, Randy. That's really sweet of you to say. And I got to say that I didn't really know what to expect. This is our first type of show like this, but you totally crushed it. I mean, you were an amazing co-host today, and would love to have you back. In fact, I was so unsure.
Crushed it.
I was so unsure how this would go that I put a button on my stream deck that would just automatically boot you off.
Nobody puts baby in the corner. That's not how this works.
But I never came close. Not even my pinky ever dusted that button. So you were amazing, and we appreciate you.
You don't have to stop. Mute me.
So
I might have to use that button right now.
This just got weird.
I tried to tempt you, but look, guys, it's been absolutely fantastic. I'll let you guys wrap it up, and I'm gonna step off the feed. Okay.
All right. Thanks for your time, man. I appreciate it.
All right. Bye.
Now I have to actually click myself back in here. Yeah, we had some technical glitches tonight, and I'm sorry about that. But luckily, you carried the show with Randy. And like I said, I much prefer listening to the show than being part of it. So thanks for answering all those questions while I was dealing with all this electronic junk.
Yeah, I loved it. I thought it was really neat. And what I'm hopeful for is we can continue to collect questions.
Hmm.
So as things come up, I don't know if, I guess through the Crit Care Now is probably, that's the email they should use, or what the best way to do it is.
Yeah,
Um,
you can always hit me up at Critical Care Now on social media. You can also email at Haney at criticalcarenow.com. And we'll get those questions. We'll build up a database, and periodically we'll just do these shows. We did the show because we didn't, we get these questions all the time, and we thought it would be just a fun show to have, answer the questions that you have. But we want to keep developing this. So keep sending in your questions. We hope to get you actually live on screen, just like we did for Randy, get you up on the screen as well. So those are things that we're working on for future iterations.
Absolutely.
Adam, what do we have coming up next
I,
week?
I was gonna look. I think so. I think our next week I think we're off. And then 10/4 is I
Right.
think our next episode, which I think is another Tuesday, if I'm
Hmm.
correct.
I
And
think so.
we're gonna follow it up, the tox episode up. So we'll do Tylenol and use of NAC in acute liver failure with our buddy Firth and Matt Saltzman.
That was a huge episode. So many people like those two together. I think people love talks, but then you sprinkle a little Salzman, you sprinkle a little Firth, and then you have the recipe for greatness. So we're going to
That's
bring those
right.
guys back on.
Yep. And we might as well let them know. I think following that, our goal 2 weeks after is to do hopefully an acute PE, an
Hmm.
approach to acute PE.
Yep.
We're still ironing out the guests, but I'm hopeful. And then after that, I think that brings us to Resus X,
That's
which
right.
it's a natural place for you to plug it.
Yeah, right. That wasn't planned, any of this, but Resus X will be kicking off November 1st through 3rd. It's just a ginormous resuscitation conference that I'm lucky enough to run every year. This is hopefully the last year we're doing it virtually, but just because it's virtual doesn't mean it's going to be any less entertaining. This is not a Zoom meeting. This is a very interactive video conference that you can come interact. We have games, prizes, all sorts of things. But at the end of the day, just teach cutting edge resuscitation. And another little plug that I'll throw in there is this Thursday, the day after tomorrow, we are doing our Resusum conference, RESUSEM conference. That's run by the Cooper folks, Cooper Emergency Medicine. We're all sold out of free tickets, but if you want to register, there's still time for you to go over to the website, resusum.com. Register. Tickets are less than $100. You get a full day of education, just great content that we're looking forward to putting out there. And then we'll be sprinkling some of that in the weeks to come under Critical Care Now, so look for that. I'm exhausted plugging myself, Adam. That's
Yeah,
enough.
just so much. There's just so much to love.
Thank you, brother. All right, Pete. Thank you for everyone. Thank you for tuning in. Don't forget to subscribe to the channel if you're not already. You can also hit that little bell to notify you whenever we go live. And sometimes we just go live just because we feel like it. So, Adam, thank you for being co-host. Thank you for carrying the show this week. Always grateful to you.
Thank you, Haney. Have a great one.
All right, take care.
See you, everyone.